Καλησπέρα σας. Σας καλωσορίζω εκ μέρους της Health Medical στην ημερίδα μας με θέμα την ιδιοπαθή εφηβική σχολίωση και την παρουσίαση ενός πρωτοποριακού συστήματος για την αντιμετώπιση της. Το Apifix θα σας το παρουσιάσει ο Professor Flowman, Διευθυντής του Τμήματος Σπονδυλικής Στήλης του Asuta Hospital και Πρόεδρος της Ισραηλινής Εταιρείας Σπονδυλικής Στήλης. Ευχαριστώ πολύ.
Good afternoon to everybody. It's my pleasure to be here. And I'll try to introduce you to the Apifix as an internal brace in adolescent idiopathic scoliosis. You all know that a long-spinal fusion is the measure of last resort when we manage adolescent idiopathic scoliosis. And usually patients, their families and surgeons do their best to avoid it. And actually when we show them the amount of or the extent of surgery, they are usually horrified because these are otherwise healthy adolescents. They don't have any other problems. So this is a rather drastic solution that we all employ. On the other hand, we know that in early cases, physiotherapy and bracing may be effective, but nevertheless, there are many cases which do not respond to exercises and bracing, and the deformity progresses. So what do? We have on one cases exercises and braces, on the other hand we have the surgery, and we don't have anything in the middle. So can we do, let's say, cases above 40 degrees that we perhaps can manage with a more conservative measure? Lately, you all know about the publication in the New England Journal of Medicine last September, which actually proved for the first time that bracing is effective in adolescent idiopathic scoliosis. And the definition in this paper in the New England Journal of Medicine was that any curve that can be kept below 50 degrees, this would be considered a success. And there are other studies by the SRS committee which shows that actually progression of less than 5 degrees is a measure of success. Others said it was progression below 10 degrees. And if we can keep the curve below 40 or 45 degrees, this would be considered a success. So we think that with the internal brace, the Apifix, actually we can keep the curves, in most of the cases, we can keep it below 35 degrees. So our criteria is even lower than the criteria for the external brace. So the concept of the Apifix combines minimal invasive or less invasive surgery with post-operative exercises and physical therapy. And the combination of both can ensure a successful result where we can keep the curve below 35 degrees. And this is an animation of the Apifix, and you will see that we choose two strategic vertebrae around the apex of the curve, and we insert a screw to each vertebra, so we have only 2 screws instead of 20 screws or whatever. And after insertion of the screws, we connect the ratchet device, which has polyaxial connectors, and Uri Anin will talk about it later on. Here you can see the device. You can actually put it like here, upside down, or you can reverse it. It will work anyhow. And about 2 weeks after surgery, exercises are begun. Usually the patients at this stage are almost pain-free and they are able to do the exercises. And you can see in this example when they do side bending to the opposite side of the curve, the ratchet elongates and captures the tooth so it cannot shorten again, and you have a gradual correction of the curve, and this actually takes advantage of the viscoelastic properties of the spine, so you can each time elongate the spine and then it relaxes and you can again do the elongation. So if it was your daughter, she is 13 years old, she is Riza 1, she has 60-degree curve. And you can see here the traditional treatment. She got 15 pedicle screws, the correction is very nice, no doubt, but it was a big surgery with significant risks of neurological and vascular injury. So perhaps this is a better solution. This is a 12-year-old female with a Riza 0. She's premenarchal, she's 63 degrees, and she can be reduced with the Apifix to 29 degrees 2 weeks after surgery. And again, another example of a 55-year-old girl, an 11-year-old girl with 55 degrees, that we can correct it to 36 degrees with the Apifix. Now this rather conservative approach of doing less but still having good success is reflected by the slides of Stephen Richards, who is the past president of the SRS. Here is a girl that is a professional football player, and she has two curves, which one is 58 degrees and the other one is 50 degrees. And he actually had two choices: either do it the traditional way with the long fusion with many pedicle screws, or just do a selective instrumentation of the thoracic curve with spontaneous correction of the lumbar curve. And this is actually the solution that he chose. Now, would it be stable? What would happen to the secondary curve? And this was actually shown by some publications that even 20 years after the surgery, the lumbar curve, which was uninstrumented, remained stable with no signs of progression. So there is a place for such an approach. This is the publication that I just cited. So if we have the traditional approach with a 40 centimeter scar with surgery that will last between 4 to 6 hours with rather prolonged hospitalization, or we can do, in a typical case, an incision of 8 or 10 centimeters with surgery that is up to 1 hour, and the girl can go home after 2 to 3 days. And here you can see 3 operated girls that were done in Romania. They are 6 weeks after surgery, and you can see the amount of exercises they can do, and obviously they are pain-free at this stage, otherwise they won't do those exercises. These are all corrective exercises trying to elongate the ratchet mechanism. And we claim that actually our internal brace is more effective potentially than the external brace, because we can keep the curves below 40 or 35 degrees. And we have to remember also that the candidates for the Apifix surgery would get the long surgery anyhow. It's not that we are operating girls that we would not operate anyhow. On the contrary, these are all girls that are candidates for the big and long surgery. So our criteria are curves up to 60 degrees curve angle. They have to be flexible. They should be either lanky type 1 or 5, and they all have only moderate rotation, not severe rotation. And what is the ultimate goal of the surgery in those girls? This is a study done in Australia where they plotted the SRS score against the postoperative care that was obtained during surgery. And you can see actually that any curve below 35 degrees, whether it was 35 or 20 or 10 degrees, they all had the same clinical results. So it's not mandatory to correct every curve to 10 degrees or 0 degrees, and a correction down to 35 degrees is certainly good if you judge the clinical outcome. Now, Uri will talk about the design of the internal brace and the characteristic mechanics.
My name is Uri. I'm not a spine surgeon, I'm an engineer, and I'll try to explain the rationale behind the design, the specific features that we have in the Apifix system, and some biomechanics issues. Basically, the Apifix system that you can also see here is a very simple device. It's an extendable rod based on ratchet mechanism with clicks or jumps of 1.3 millimeters, very small increments, and this is what does the work. But in order to let it work and to work safely, we also have a unique polyaxial joint at both ends of the implant. And this is very important, you can see it here, to allow the implant to be flexible and to accommodate the changes that the implant sees along the correction period. We also have a control pin located here in the center. And by switching this control pin that you can access percutaneously at any point after the surgery, you can switch the internal mechanism between ratchet, which is a standard position, or you can unlock it. If for some reason you have overcorrection, you have pain, or you want to open it for any way, you can just open it, or you can lock the system and then it becomes just a rigid rod. We also have a ceramic coating all over the implant. This implant is made of titanium, but it is coated by ceramic coating, which minimizes wear. The ceramic coating has also a very nice feature that no bacteria can grow on this coating. And this may be a contribution to the fact that we have seen 0 infections in our cases so far. But yet, experienced people like you, when you see such a new system, will have some concern, of course. And we talk with many surgeons and we try to identify the main concern and to address them. So we believe that the main concerns are what would happen to the untreated secondary curve once we treat only the main curve. Will we face screw breakage or loosening? And what would happen above and below the implant? So, as Professor Kroman has mentioned before, there is now today a good literature that tells us that once you correct the major curve, the secondary curve would get spontaneously corrected and would hold this correction for many years. Regarding the strength and durability of the implant, there is a standard test method, ASTM F1717, that is being used to test the standard fusion system that you all use every day. And we have sent our system to Germany, to Endolab, which is a special lab that deals with this kind of biomechanic test. Now, this standard fusion system typically holds 300 Newton for 5 million cycles, which is considered, unlimited number of cycles. our system was able to stand 1,000 Newton, 3 times more. And the question is, how? What's the difference? And this is the difference. If you take such a fusion system and you load it, you have a huge moment here inside. And when you fatigue it, you load it again and again, that's what finally breaks the system. With Apifix, we have this polyaxial joint, and the system actually sees only pure compressive loading, no moment at all. Also, no moment can be transferred between the system and the screw, and that helps to prevent screw loosening in the bone-screw interface. This is a very important feature. Now, many surgeons ask us, how do we know that the system works? And here you can see examples. In some cases, that depends on the parameter of the X-ray machine. You simply can, count the teeth inside the mechanism. In other cases, you can do a simple measurement that tells you how many teeth the system has progressed. So we can follow the patient and see that the physiotherapy works and the correction is taking place. Here we have one example of a patient along 1 full year. And you can see the progress that we can count teeth by teeth when she gets down from 42 to 24 degrees. Now, in order to meet the different anatomy of different patients, we have 6 different lengths of the system. The internal mechanism is absolutely the same, but the length of the system is different. And we have 8 different dimensions of screws that are otherwise standard pedicle screws that covers all cases that we met so far. We also have some additional configuration that we never used so far, but they exist. If for some reason you cannot trust one of the screws and you want to share the load over 2 screws of the same vertebra, of 2 vertebrae, we have extended crossbar that we can connect the system to it and reduce your fear. Now, what about the physical therapy? Physical therapy is simple. This is all what they need to do. And I know this is not a typical patient. This is just the expert who developed the exercise. But after 2 weeks after the operation, they start to do these 5 simple exercises at home. They come every few weeks to a follow-up to see a specialist that makes sure that they do it right and that they don't have any specific problem. But everything can be done at home. They don't need to come every week or every day to see a specialist. And so far we see it works very nice.
I'll take you some examples of the cases that we did. So again, our criteria were lanky type 1 and 5 curves, curve angle of 40 to 60 degrees, Reese's sign of 1 to 4, and what is very important, a flexible curve. This was done as a clinical trial in multi-center in Hungary, Israel, and Romania, and it was approved by the internal review board. So far we did 22 cases. This week we did the 22nd case, which went very well. And what is most important, that 5 of the 22 cases already finished more than 1 year of follow-up. Here's a typical case, 15-year-old girl with a 43-degree curve angle. You can see the instrumented vertebra. You can see her exercising, and you can see that the curve was gradually corrected from 43 degrees pre-op to 32 degrees at 1 year follow-up. You can see the X-ray on your right hand side that she's very well balanced. The secondary curves did not increase, actually they decreased. Another case, 43 degrees, she's a bit older, 16. Here are the post-op X-ray, and you can see again that she was corrected gradually from 43 degrees down to 29 degrees at 1 year follow-up. And you can see again the amount of flexibility that can be obtained with this kind of device. Another case, very simple, I'm sorry, I'm going back. Another case, 13-year-old girl, this time 53 degrees, Reason 1. This is the instrumentation, and she was corrected from 53 degrees to 30 at 2 weeks to 26 at 3 months. Another case, 45 degrees. This is the amount of correction that you can achieve after 3 months down to 31 degrees. We can also instrument smaller curves. This is a 40-degree curve. And you can see the 1 year follow-up, she's now 28 degrees. Again, you can see the amount of flexibility. This is a Leckie type 5 curve, 17-year-old girl, painful thoracolumbar curve, 34 degrees. You can see the amount of rotation at the apex of the curve. And you can see that she's corrected down to 11 degrees. Now in this case you can see that the rotation was corrected as well. Now the device is not aimed at correcting the rotation, but some correction of the rotation can occur just by reducing the curve. And remember that all the curves that we are doing with the system are mild cases, moderate cases, where the rotation is not the main issue. Another example of a 53-degree curve that is corrected after 6 months to 32 degrees. And you can see here actually the amount of correction over time. You can see here on your left, you can see the void space or the window below the ratchet piece, which actually is elongated very clearly at the follow-up X-ray after 6 weeks. Another thing which I have to mention, that no attempt to do a fusion was done in those cases. Those cases are all were done without any fusion. It is anticipated that some stabilization will occur over time, probably just by scarring or perhaps some spontaneous fusion, we don't know. But so far we didn't have any clear indication that we do have to do a fusion. Now I know that this is very contradictory because we always do a spondylodesis when we do a scoliosis correction. But this is a different concept and probably we do not have to do a fusion. So far we have good correction of the curve. We have reductions of the secondary curves. We didn't see any adding on phenomena. There is a good control of the sagittal contour, no screw loosening, no screw breakage. Most of the spinal mobility is preserved, and as I said just before, there is no need for fusion. And we think that the success of the system relies on 3 factors. First of all, there is a gradual correction by motion control. There is some gross modulation, and the polyaxial connectors prevent mechanical failure. So we can see actually that this system resembles somewhat the vertebral stapling, but the vertebral stapling is done on the other side of the curve, and it's done in multiple segments, while with the Apifix we deal only with a very small segment of the entire curve. And this is achieved probably by unloading the compression process on the concave growth plate, and the destruction stimulates actually concave growth, and convex growth inhibition occurs by compressing the growth plate. And unlike a simple destruction rod, it allows continued elongation through motion and active concave growth. Uri?
We'll go over some of the considerations when doing the Apifix system. There are two major issues with this system. First is the patient selection. And Professor Floman has explained the very simple and clear indications that we have for this system. And the other issue is, where do we locate the screws, the two screws? And we will ask this question many times, so I'll try to explain, give you 3 examples of how we calculate and do it. So the first step is simply to draw a line that gives a direction of every single vertebra. And when you look at those lines, you see that on the external side of the curve, the lines are parallel. And inside the curve, towards the apex, there is an angle between the lines. So when the lines are parallel, there is no need for correction. And we place the two screws just where the lines are not parallel, where the vertebrae are not parallel, and you need to correct the location or the angle between them. Another example, again, we do the same process. We draw the line. We look, where do we start to see an angle between those lines, and then we place the screws. But in this case, and this is a typical case that we are doing, where we bridge 3 motion segments, 3 discs. But you can see that above the upper screw, we give up. If you do it this way, we give up for something like 5-7 degrees. So there is an option to go 1 level higher and bridge 4 segments and gain those additional degrees. And this is a balance, and we have to consider for every specific case what is better for this specific patient, to give up for some degrees and have a smaller scar and treat less segments, or to go up a little more and to have a better correction with the price of a bigger scar and more treated levels. This is a columbar curve, but the considerations are just the same. And you can see after you get used to this way of thinking, it's very simple to make a decision where to put the screws in the optimal location for this patient. Now another issue is how we deal with those 2 screws. Typically, you have 20 screws, and the load is being shared over 20 screws. With the Apifix, we have only 2 screws. So a special attention needs to be taken for the insertion, selection of any single screw. And here we have some specific requests that may be in line, may be different from what you do typically. The first request is try not to use a tap. We believe that if you don't use a tap, the purchase of the bone by the screw is better. The screw is self-taping. You just need to open the cortex and you can drive it in. And this works well. Another request is to use the biggest diameter and the longest length that you can in order to have the best purchase into the vertebra. And then drive the screw as much as you can, like the example that you see here. But yet, we know that there are some conservative spine surgeons that would say, you know, this is 2 screws, no fusion, it's going to fail. And I want to try and address again this issue. This is a type of failure that you see in the literature, you see in the history. When you have long contract, you don't have good fusion, system fails. And again, when a patient, even with a single segment fusion, is moving from flexion extension, like you see here, the load on those 2 screws is huge. It's a huge load. The whole body weight, the whole muscle strength are acting on this contrast. And of course, if there is no fusion, at a certain point, it will fail. Because the screw is fixed in trajectory A. And the body is trying to move it to trajectory B. So there is a fight, there is a war, and someone has to give up. And typically, it's the screw or the rod. But let's see what happened with Apifix. Here we have an example. Post-op, the screw is in trajectory A. After 3 months, the screw, for many reasons, maybe because of the elongation, is in trajectory B. But is there any loading of the system? 0. The loading of this system under this change from A to B is 0. And here is a polyaxiality that you have that solves this specific issue. And this is a key point that needs to be understood. This is a different system that acts in a different way. In flexion extension, no loading. In axial rotation, no loading. It just limits the load of the lateral bending. And again, as Professor Ploman has explained, this load of the correction goes down very fast. Initially, you see a high load after you do a distraction, or after the patient gains some correction. But after very short time, the loading goes down and down. And so far, no failures, no screw loosening, no breakage. Now what about the implant consideration? When you place the screw, just like I explained before, and you have some correction, the implant would elongate. The elongation that we have inside in this implant is 20 millimeters. We want to save the whole budget of 20 millimeters for the correction process. So for example, if you have the distance between the screw, 72 millimeters, and you can choose an implant which is initially 70 or 75. It's much better to take the 75. You do some distraction, small distraction on the table, and then you still have the full amount of 20 millimeters for the elongation over time. In those cases where you bridge 4 segments, of course you have a bigger lever arm, bigger moment, you'll have better correction, but you need more elongation. because the elongation needed to correct 4 segments is more than to correct 3 segments. That's why we have, with the bigger implant, 85 and up, we have 30 millimeters of elongation, and in those cases you better choose the longer one.
So here are some frequent questions that are raised by the surgeons who see the system. First of all, we already talked about it, the correction of rotation. So typically in the curves that we are dealing with Apifix, the rotation is not the main issue, but as I said before, some correction of the rotation is spontaneously occurring because of the reduction in the cobalt. The other question is, what do we do? We haven't done a fusion. We are now 2 or 3 years after the surgery. What do we do? So theoretically, we can approach percutaneously the control pin and put the system free, meaning that the rod can shorten again. Now, if the curve is stable, the rod won't be short, and then the curve will stay probably the same. Then, theoretically, we can go in and take out the rod, or the system as a whole. On the other hand, if we see that the rod does get shorter, then maybe we should go in and do a small limited fusion. So these are open questions, but we have the capability of seeing to which direction should we go. Should we go in and remove the system, or should we go in and add a limited fusion? Another question is, we always have to choose the flexible curves. If we have a rigid curve, we probably should not employ the Apifix, because we want to get the curve well below 35 degrees, where we think it will stay stable for at least the next 20 or 30 years. Any other questions that you have? Yes.
Mr. Froman, may I ask you please, how can anticipate the main problem, the cosmetic problem, in case that the patient has a curve of 45-50 degrees, and as you know, the ribs are a main issue. So, applying this system, the ribs are going to stay the same. You cannot do any derotation, you cannot do any reduction of the rib hub. So the patient has less degrees of scoliosis, but the same rib hub.
Well, as you saw, the study from Australia actually shows that the SRS score is not dependent on the post-operative cob angle if it's well below 35 degrees. And the SRS score is actually relying on rib hump and self-image and other things. So there is no direct correlation between the post-op cob angle or the post-op rotation and the satisfaction by the patient.
This is what I'm talking about. We will succeed to reduce the scoliotic curve, but the rib hub is going to stay the same.
But as I showed in this slide, there was a plot of the SRS score and the cob angle, and the satisfaction was very good with 35 degrees and 10 degrees.
35 degrees, you cannot even see the curve. That's why the cob angle and SRS have no statistical relationship.
I didn't get your question. Can you repeat it?
Yes. In 35 degrees, you cannot even see the curve. And that's why the SRS score and the curve angle have no statistical relationship.
Okay.
So what you're talking about has no meaning for curves above 35.
No, I don't think so, because if you look at the corrections, you know, Lanky and others claim that they can derotate. But actually, if you look at the X-rays, the derotation is not that significant. And there are many correcting the cobweb. And yet the patients are satisfied.
Patients are satisfied with, they have the same satisfaction as well with, in long term, with Harrington rods.
Okay, so what is your question?
I have no question.
Okay.
This is perhaps since we are in a country with a crisis, we can always go back to good Harrington rods.
Yes.
There is any, I would like to ask, you put the screws from one side. There is any biomechanical evidence to put the screws obliquely, say, from the one side of the vertebra and the other side in the down, the lower vertebra, something like that?
It's certainly a possibility, but we didn't try it yet. But you could use two rods on each curve. Yes.
How long are your results? How long is the follow-up?
As I said, we have 5 patients which completed more than 1 year follow-up. Actually, our first patient is going to be in April, 2 years out of surgery, and she's still very well with no evidence of any problem. Yes.
Professor, in the long term, are you expecting any junctional problems? I mean, from our experience with ground rods, we know that unless we instrument long way up and long way down, sometimes even backwards, we see quite often, junctional kyphosis and compensation. Your system, which is a rigid system, you stop rod short on the upper and lower ends, sometimes with the cup angle. So, do you expect any junctional problems along the way?
No, I don't expect it, because first of all, our patients are older than the patients we use the ground growth, so they are toward the end of their spinal growth. And as I showed with the example of the study out of Texas, that even 20 years after the surgery, you don't see any junctional problems and you don't see any increase in the uninstrumented vertebra.
Sorry, can you repeat what is the age when you recommend this system?
We recommend it for patients between reserve 1 or maybe even reserve 0 and reserve 4 with curves between 40 and 60 degrees. Yes.
I don't understand very well the mechanism of elongation. That means that each time that the girl bends over the ratchet elongates.
Yes.
Yes. So if a patient is not very carefully in a period of 2 days, it could be took all the elongation.
Okay, first of all, we didn't observe any overcorrection yet. But in case it might happen, we have the mechanism to release the control pin and the curve can collapse again. But so far we haven't seen any overcorrection. Usually the correction of the ratchet stops around 3 to 4 or 5 months. Yes.
If I have understood correctly, you're using only active exercises
Yes.
after the operation.
Yes.
Have you considered using passive exercises? I mean, somebody helping the patient to do the exercises by
The physiotherapist that sees the patient at follow-up visits does help with some lateral forces or rotation forces, but most of the exercises are done by the patient on his own without any external help.
without any passive
Right.
right? Only the patient is doing everything by herself.
Right.
Have you measured the forces acting upon the spine with this exercises?
Not yet.
Not yet. Thank you.
Yes.
When I consider this elongation, I can imagine over the first short period there is some elongation, and then probably it stops.
Right.
Or it diminishes a lot.
Mm-hmm.
How long is the time where this correction occurs in your study, and when does it stop?
Well, in most of the cases, the correction took place within the first 3 to 5 or 6 months, and after that, we don't see any elongation anymore. Although Uri Alin showed a case where it was prominent during 1 year, but in most cases, it's between 3 to 6 months.
And if I may continue my question, could it be theoretically that you can do during the operation the elongation, or
You can do the initial correction or initial elongation during the surgery, of course. Just take a distractor and jack up the ratchet mechanism. But we usually try to do little elongation because we don't want to put stress on the screws.
What about traction?
Post-operative traction,
Yeah. Did you notice?
we haven't done it, but you could try it. But I think the main issue is that you should take advantage of the viscoelastic properties of the spine. So if you do it gradually, you working in a safe fashion. If you do a forced contraction, then maybe you overload the system. Yes.
What about some side bending x-rays before the operation? Do you have
Yeah, we do routinely side bending x-rays before the operation to see that the curve is flexible.
That's actually my question. Do you compare the side bending x-rays before the operation and your final results? What is the connection of the side bending x-rays?
We don't have enough cases to tell you that, but that's certainly one thing that we will investigate.
I would actually just do a comment. I would prefer to see long X-rays and clinical cases before the clinical pictures before the operation and after the operation on this. Because I haven't seen them.
The long X-rays.
I need long X-rays and also clinical pictures before and after.
I agree. Yes.
If you have a scoliosis of 50 degrees, for instance, and did you notice that, you told us that the elongation after 6 months, after 5 months, it's stopped. And how much can you correct this in scoliosis of 50 degrees?
You can correct it well below 30 degrees or maybe even 25 degrees.
And why the elongation stops after 5 months? Did you find
Probably because of fibrosis and stiffening of the segment.
Can we replace the mechanism with a longer one?
Yes, theoretically we can replace it with a longer one and try to continue to do the elongation. But if you have a 25 degrees or 30 degrees curve, I think the patient is satisfied, the surgeon is satisfied. Why to bother to do more?
Yes. I sit here with discussing with my colleagues the subject that always relatives of the girl want to have a straight spine soon after the operation. And if after the operation, look at the X-ray that there is a curve of 25, 30 degrees up and another 25, 30 degrees down, okay, that's okay. We know that this is balanced and our surgeons were satisfied. But the parents, they will see that there is still 35 degrees upstairs and another 35 degrees down. I'm not satisfied. And this may affect their opinion about the surgery.
Yeah, but that's why we have the SRS code. Actually, the patient is
yes, but the patient
judging herself or himself about the success of the surgery, not the parents.
Allow me to say that the relatives do not know something about SRS score. They know the picture. And this is something difficult to be accepted.
We should avoid showing the X-rays. Should avoid showing
No X-ray.
I want to address your point. I get emails, telephone calls from patients all over the world every day, typically several of them, of patients and families that simply don't want to have the standard procedure. They are very concerned about having a stiff spine, about the risk of the operation, about what would happen for this long spinal fusion in 20 or 30 years. They are very, very concerned. We have another problem. We have patients and families that are outside our indications and demand to do this specific procedure. They don't want to do anything else. I believe
I take your point.
Yes, but how we can assure them what it will be happened after 20 years? You don't know, and we don't know. Okay.
But with the Apifix system, one important thing is that no bridge is burned. You can always go and do the standard procedure. The main risk is one additional surgery.
Well, I understand the important points of the presentation. I take your message. But I insist that parents are very curious. Although they want to have less operations, less complications, they take the X-ray soon after the operation or a month after the operation. They go to my good friend here and he will say, for example, he's a good guy, but he will say, oh my good God, he's still there, 35 degrees. What did he do? And then he go to my friend Nick Sakouris, the good guy also, but will say, I can see another 40 degrees there, and I'm not sure that he tried hard to restore. And he will smile. Then after that, the parents are going back to me and they will say, wrong selection. No, but tell me now. But what should I do? Write to you and ask you your help, my good friend. And then we can see this every day. And then a good lawyer will come and say, look, show me papers, show me long-term follow-up, 5 years, 10 years. You don't have this. So why did you choose this method when there is no long-term follow-up? What should be my reply?
Your reply would be that you haven't burned any bridges, that you did simpler surgery, safer surgery, and if you have to, you can do the usual surgery.
Yeah, but the truth is that usually they can sue you for damages,
Sorry.
not because there are people can sue you for damages, not because they're not happy with the result. So if you do damage with this method or any other method, you are liable. If they're not happy, then it's up to them. They won't sue you again, but they cannot sue you. They cannot sue you for damages.
Yes, but if my friend Nick say that, look, it's not well corrected, it could be done something more. And having still 35 degrees, there is a strong possibility that 10 years later, 35 should be 55 or 45 degrees, and then should start to have back pain at the transitional zone, and your girl who is now 15 years old, and then at that time she'll be 25 years or 30 years old, then she's going to have pain. Coming now.
Yeah, there's an issue.
Yeah.
But
Whatever.
And
Like
this
to
probably be retired.
And unfortunately, it's going to be Nixakuris. If he was something careless, the conditions will be very worse.
Yes.
In that case, probably the parents is going to ask, okay, you have not a very good adjustment of that, but it's going to be worse. So I think your system is made better. There is any possibility to be worse the curve using that system?
There's always a possibility, but as we know from the studies that I cited, that usually the secondary curves remain stable, they don't increase. And the gain by preserving the motion is much more important than adding 5 or 10 degrees of correction.
That's a good point.
And if it will be necessary in the future, it will be a surgical procedure, a long surgical procedure. You are okay with me? You agree with me?
I agree that if we cannot correct the...
But we correct.
No, we correct, let's say that the curve is corrected to 35 degrees or less.
Yeah.
Now the literature tells that curves that are below 35 degrees have a very, very low chance to progress over time. If they do progress, you can always go and do the standard procedure.
We told the same thing. But from our point of view, it's very difficult to explain that maybe it will be necessary a second operation. No. I don't know how you convince the Israeli
with
people.
With a long surgery, there's always the chance for a second operation.
Yeah, sure. Yeah.
So what's the difference?
What's the difference?
Do you have concerns about sagittal profile with this device?
Yeah, there is some concern about the sagittal profile because if you do destruction, you get some kyphosis. So it's mainly a concern for perhaps the Lenki type 5 curve. Because with the Lenki type 1, usually you have hypokyphosis. So if you increase a bit the kyphosis, no harm is done.
95?
Say it again.
95?
95, there is some concern, yeah. Yes.
Professor, I do have to congratulate you on your work, because we're actually dealing with progressive scoliosis, and we have to bear in mind that we're dealing with young girls, right?
You recommend this system in sports adults, in sports adolescents?
Yes.
I think I'd also to ask what happens because of this motion of the screws with the soft tissues near to the ball joints. Are there any irritations or something because of this micro movement which happens at the ball joints?
So far, we didn't have any complaint or complications. I just want to add one point about the amount of correction and bring you back to the beginning of the presentation. The SRS, which I believe, the best expert in this field, made the bar of success in 50 degrees for external brace. Means everyone that is below 50 degrees is considered a success. And here we come and we offer you a new option to have, not to jump from external brace that is paid to the long spinal fusion, but to have the internal brace, a minimal procedure that can reduce the curve to the safe zone, below 35 degrees, and maintain it there. This is the option that Apifix brings. And so far, we see that with those patients we did, that they are very satisfied with being below 35 degrees.
Yes, but we must tell to the parents that this method don't replace surgical one, but replace the brace. Huh?
It's in between.
No. We can't explain to the parents this between.
Yes.
Yeah, there is no, for them there is no any between. You told us that this is an internal brace. Yeah, okay. So we must tell to the patients that this is not this method. Don't replace a surgical method, but replace.
And we're dealing with scoliosis, which we do have to do something about that. If we don't do anything, this type of curves are going to progress. And you told us that if we don't do anything about this type of scoliosis, if we just leave them without doing anything, then after a couple of years, scoliosis of type 1 or type 5, according to Lenke classifications, then we're going to do actual surgery with these girls. So with Apifix, you're telling us that you have found a minimal invasive brace, and you presented to us actually you're premature, you might say, results, right?
Early,
Early,
not premature.
early results. Well, personally, I'm willing to try it. Because I prefer to have a young girl without a brace or without spinal fusion. And we all know that medicine, well, either you dare to do something or you go the old way. Well, I have to congratulate.
Thank you.
Thank you very much.
Okay.
Shall we call it off?
Okay.
Δεν υπάρχει κάποια άλλη ερώτηση.